You are looking at Washington, D.C., and we are at TCT, but we're actually talking about a paper that started back at TCT last year, and then at ACC 16. One of the interesting stories was the RevElution Study. And now we are here at TCT 16, one full year later, and there is more to talk about, and the paper is about to publish in JACC Interventions. I think by the time this goes up online, it'll definitely be there. And it is being simultaneously published online ahead of print to coincide with the data presented here at TCT. I'm with Dr. Stephen Worthley, who is an MD, PhD, and unless it's changed, Professor of Cardiovascular Medicine at the University of Adelaide, and an interventional cardiologist at the Royal Adelaide Hospital. Okay, first in human evaluation of a novel polymer-free drug-filled stent, angiographic IVUS, OCT, and clinical outcomes from the RevElution Study. I am tempted to just say what's new, since this is our third time together, but I guess we should begin with the stent itself, because it certainly is new.
Look, it's a novel technology, and just to perhaps spend 20 seconds just to describe it. So what it is, it's based upon a tri-layer wire, and it leverages what's called the continuous sinusoidal technology from a currently available clinical stent, which is the Integrity stent, the Integrity platform. What they've been able to do then is decore the inner part of that wire, creating a continuous internal lumen through which there is coating of sirolimus, so the anti-proliferative agent. Then on the abluminal side, laser drilled holes that are 20 microns in diameter are drilled, and what that allows is for natural diffusion of that sirolimus coating in that continual internal chamber to diffuse slowly into the vessel wall, and so 90% of that drug is diffused over 90 days, which is consistent with what our current drug-eluting stents are. So the technology, still in a traditional thin strut stent, has allowed us to have no polymer and yet have the elution kinetics of a current drug-eluting stent.
Now, once it's empty, you just have a very hollow stent that's left behind, obviously.
Yes, yep.
But what happens to it over time? Is it just like a normal stent in that way? Even though it's hollow, it's going to stick around?
It is. It's a permanent metallic scaffold. So the elements that are left, there's a tantalum middle layer, which improves the radio opacity, and then there's a cobalt chromium outer part of the stent frame, which has actually been modified to maintain a strong outward radial force.
So what you're presenting here at TCT and reporting in JACC Interventions describes results through 9 months. I think at TCT 1 year ago it was 1 month, and now we're a year later, you get the 9-month data. Tell me what you found.
Well, the 9-month was the primary endpoint data. So what we presented today was that the primary endpoint for the trial. We presented angiographic in-stent late lumen loss, as well as the OCT data that we had available from 1, 3 and 9 months, and the IVUS information. So what we found is that we have a very efficacious platform. So the in-stent late lumen loss was 0.26 millimetres, and when compared to a historical comparator, the Resolute stent from the Resolute US study, we propensity matched them for a host of demographic and angiographic criteria. That in-stent late lumen loss was 0.36. So it was not inferior to that result, and indeed borderline superior. For all that being said, we showed that in fact the premise of it was that it's efficacious. The second step was the safety bit. Could the fact that there's no polymer mean that we would have an earlier healing profile? So the 1-month data, which we'd touched on back at TCT last year, we've now analysed in depth for all of the 15 patients, and the strut coverage, so the healing that had happened by tissue over the stents, 91.4% of the struts were covered at 1 month already. So it's a surrogate, but it's a step toward that healing profile. So we've got great efficacy from the 9-month in-stent late lumen loss information. We've got a safety index from that very early OCT data, and it certainly sets the platform for future trials that are already being imagined and considered for this product.
Now, you're at 9 months in terms of presenting the data. You're working out to 24, correct?
Yes. So you're right. So there's two arms to this, the RevElution program. So I presented the first 50 patients in the 9-month cohort, but there is a 24-month cohort too. So we will look at evidence of what happens to a neointimal proliferation over 24 months. So we'll have a very complete data set from 1, 2, 3, 6, 9 and 24 months with the product.
So if everything continues to go as well as it is so far, where is this one going to fit in?
So where this is going to fit in is we've seen here, and Ricky, I'm sure you're over it. I mean, at TCT we have the 3-year data from Absorb-2, which really continues to show a divergence in an adverse way for the the bioresorbable vascular scaffold versus science. And I think it's really put the cat amongst the pigeons around the bioresorbable products. So there's been a real move back to, well, you know, what do we have in terms of metallic permanent drug-eluting stents? The bar's pretty high. So the premise of this product will be that we have something that is going to be at least as efficacious as that, but by potentially healing sooner, that we may be able to erode into that dual antiplatelet therapy. And indeed, if we could show that even 1 month of dual antiplatelet therapy was all that was required, well, in our patients that are higher risk for bleeding, we've got a product that potentially is safer than even our current best generation drug-eluting stents.
Well, congratulations. This has been wonderful. I hope to see you again when you have more data further down the line. Now, at TCT 16, we have a lot of the papers simultaneously published online. See JACC Interventions, and please go online for CardioSource World News, where I'm Executive Editor Rick McGuire.